Can you talk me through a little bit about how do they work? I mean, how did you define value, and then how did you try to put payment associated with it?
Yeah, I think the starting point is what we built is a scorecard, we call it. So that's for us a small number of indicators on outcome, costs and process indicators. And it also includes treatment options and also case mix variables. But the main thing is the outcome, the cost and the process indicators. And that's our scorecard, which defines value for the patient. And we make that scorecard with the patients also, with individual patients in the hospital, but also with patient organizations. And we check, okay, is this really important for the patient to define the value? And then what we have is the improvement teams in each hospitals, and also with the specialists, nurses, they're involved, and we start collecting the data in the indicators, and we started, I think, really important, the discussion between the professionals, the healthcare professionals, what are the results of our care, and how can we improve? And with the 7 hospitals, we compare our results. And if you compare, you see variation between the hospitals. And then the interesting part is, okay, can we explain this variation? Is it the data that's not right or anything else? Or is it something we do differently? And then it's getting really interesting, of course, because then you have potential to improve. You can see one hospital is scoring better on reoperation rates. Okay, then we visit that hospital, or you have the debate between the healthcare professionals. What is the difference you do in the healthcare process? And then professionals have intrinsic motivation in working in healthcare. They say immediately start improving, because you don't want your patient necessarily in the hospital. So there's really no financial incentive in a way necessary to start that debate.
Well, under the old financial model, there was incentive to have that patient in the hospital.
Yeah, but our experience is, despite that incentive, people they work in healthcare not for the money per se, but for making people better. But of course, what you see is also a part, you get some mileage on that part, like you get improvement to a certain level. But of course, we see also the debate about, okay, that the current model of volume-based is a negative reimbursement on this kind of improvements. So then you have, of course, the debate from, okay, how can we reduce that negative reimbursement that is blocking the improvement? And that's, I think, what we tend to do is really start with the problem in the healthcare process. You want to solve a problem for the healthcare professionals and for the patients, not necessarily start with a payment model. And then what we do is we have a certain problem. For example, if you stay overnight in hospital, you get more money. We reduce that to you can stay only for a day in hospital. It will reduce the working load for the nurses, etc., and for the specialists, and it's better for the patient because they're not staying the night in the hospital but in their own bed. But of course you get less money. So then the interesting discussion goes on, okay, how can you change the reimbursement model for going more daily in day care? And that's what we did with breast cancer, is then we had a separate contract with the health insurers. Okay, can we change not on volume, but on the number of admission at a day or operations? So that's what we changed then.
So if I can drill into that a little bit. So let's imagine you get paid the same whether the patient spends the night or not, as long as you're doing these criteria or these processes or getting certain results.
Yeah. So that you get paid more or less the same. And that is really interesting, of course. Volume-based, you get money if they stay overnight, but your goal should not be to let them sleep overnight. So that's the thing we changed, okay? And then you see, but you have to start with that problem in the healthcare delivery. You say, okay, we have not enough nurses and doctors, and it is not good for the patient. So why? Oh, it's a money-driven issue. Okay, then you have to change it. And that's an interesting question. You start with the problem in the healthcare, and then what is the key to fix it? Or what I think sometimes happens, we have a contract, and then we find something which should fix it or something. So that's a different way around. So we don't start with health insurers about making contract per se. Let's really start with the issue in the care process.
That's a great description. How do you go about identifying them? Do you have a board of clinician representatives or people who come together? What's dysfunctional in the system? How do you get these to bubble to the top?
For each patient condition, we have from each hospital one medical lead, we call it, so as a specialist. We bring them together from the 7 hospitals once every 6 months. And they debate on the basis of our data, the scorecard. They see the variation and say, okay, we should do something about our problem. And that's where the ideas pop up from, okay, well, can we change it? And then you get, of course, a debate sometimes about money, but there's where the ideas bubble up from what should we address. And it can be specific per hospital. Sometimes, for example, one hospital has already made that step for overnight stay, for example. But that varies a bit, of course. But that's once every 6 months we bring together the clinical leaders for that condition.
Tell me about the scorecards, because that's been a big deal for several years. Did you get this from the research or from a hospital association, or did you build it from scratch with input?
No, we started with ICHOM sets for the outcome indicators, because I think it's really important to try to connect as much as possible with international standards or national standards. So we started with ICHOM sets, and then we had a debate with patient groups, for example, and also with the professionals. Are some items missing? And in the ICHOM set, for example, cost indicators, process indicators are not included because it's an outcome set, of course. So that's what we did an analysis for cost drivers. What are the biggest cost drivers for a certain patient group? Then we should make some indicators on that part. And also for process, especially for process, we did a lot of discussion with patients. What is important for your healthcare process as a patient? For example, the waiting times, or what is the time between diagnosis and treatment plan. It's really important for patients that in certain period between diagnosed for breast cancer and having a plan is really important, we found out. Perhaps more important than the time from treatment plan to your operation. If you have a plan that's really all ready, I think really comforting with it in certain really difficult periods in your life as a patient.
So it sounds like you started with the outcome measures and the patient satisfaction. I heard both of those.
Yeah, both.
And then did you back into what are the processes that make those happen? Did you go kind of upstream from outcome and satisfaction to processes, clinical processes or operational processes? So like with the ICHOM, ICHOM is all about outcome measures and then patient satisfaction measures. So we might hypothesize that we would get those accomplished if we had processes, clinical process, business process. So I'm trying to think about how you build the scorecard so that it's outcomes, but also processes. Are people doing what we think are the right things that are supposed to produce those outcomes? That's what I mean.
Every half year we have the debate between the medical leads about what's the results, and then they go back to their own hospital, and they have an improvement team in their own hospital specific for breast cancer, birth care, etc. And they go back to their own improvement team. There's a patient, there's a radiologist, everybody involved, and they discuss, okay, for our hospital, for our processes, how should we change something? And they do sometimes a process analysis or what it takes to get the specific local problem clear, and then they, of course, start with changing and improving the healthcare for themselves. So that's the mechanism we find from discussing between the hospitals the scorecard, and then we have the improvement teams that are really vital to make a transition to what's going to be changed in the local processes in the healthcare in the hospital itself.
You've also talked about that clinical board that even all the way to the Santion board is half the board of 14 people. But you mentioned the patient, so how do you get the patient input? Is there a patient board, or you just grab somebody?
Yeah, no, I think we have, every hospital has, of course, its own patient board, specific for our value-based healthcare program. We have also, in each improvement team in the hospital, we have a patient seated, or depending on the condition, for example, for lung cancer or stroke, it's a bit more difficult because of the nature of the disease. But we have focus groups for chronic care, for example. So we find the best suiting way to have the patient input there. But in addition, we have the contacts with the national patient advocate organizations and discuss with them. So there's a lot of effort to get as much input as we can there.
So they haven't come to you yet with like a shared savings?
But that's we tried some pilots with it, but it is with breast cancer we did it. It was a pilot, but it was a lot of work to do it. And also what we find out is that you can ask a question if the improvement in the quality and in the cost, what we have achieved in that part, whether because of the contracts with the health insurers or was it because of the intrinsic motivation of the specialist involved. And we're not sure about it yet. I mean, we just did the evaluation. So that's, I think, an interesting way to explore with health insurers how to make the next step in that part. For example, one of the ideas we have is in what way can you reimburse people that work on improving the healthcare? So improvement teams, if you facilitate that a bit more, and do you trust each other enough between the healthcare insurers and the providers that the results of that improvement teams are such a way that will benefit at the end the healthcare insurers and the patients? But do you make a KPIs kind of contract, bundle payments, etc.? And our specialists like, yeah, but then I have to select patients that are really sick. I don't want to treatment them or that kind of tricky parts. So do you make reimbursement for the improvement part and trust that the results will be that? And you have to, of course, measure it a bit, but that's the fine two ways you can look at the same subjects, like result appointment agreement or on the process of improvement. That's, I think, interesting to what we're currently exploring, what should work.
I'm glad you brought up the issue I'll call risk selection or adverse selection, depending on your perspective. Yeah. So what's happening, what I read the most about now is risk adjustment. So, okay, yes, if this patient is more costly, just like with the DRG, they would slip into the higher complication level of the DRG. A lot of value-based arrangements are doing something like that. So, well, this person is sicker based on diagnosis codes or some utilization or a formula that includes all of those. Yeah. So we'll give you X amount more money or percent more money. Do you see that happening so that your docs don't purposely or inadvertently, subconsciously select easier patients?
In the breast cancer contract we didn't do it, but it was really a pilot in that way. So I think it worked quite well for that part. But it's a really major discussion with the doctors because they trust the risk adjustment that way that it works and is it an accurate reflection of the difficult patient so I have a lot of doctors that they don't believe in the risk that it will work, the risk adjustment. I see a lot of resistance against that kind of contracts.
So what do they propose in its place? Because not all patients that have the same diagnosis code are the same. No. Some are much more complicated. Yep. Maybe even if it's just the social determinants of health that make your odds better or worse. Yeah. So how do the docs say we should approach this?
Some doctors, they believe that we should try it and see how it works. Some others say more on the reimbursers as for improving. And if you reimburse the improving part, then trust us that we do the right improvements for the patient and for the healthcare. So that's a bit softer model perhaps, but that's what they tend to think that could work. So,
I talked to one insurer about this very issue because I always hear about risk adjustment and a bundle that follows the patient from a defined starting point to a defined ending point, whether that's time or a patient path through the continuum of care. And this person said, well, no, we don't want to do that. We instead want to take, let's say, cancer care for one of your hospitals. And the person used the term bundle, but really meant like a global payment or a capitated payment for that service line. So instead they'd say, well, last year you spent this many 100 million euros on breast cancer care. And this year we want to spend no more than that per capita, and we'll give you that budget. And so you produce these outcomes, and this is your predetermined, prepaid, or at least prescribed budget. So that was a different way of conceptualizing a bundle payment. And the nice thing about that, the person said, was, well, we don't have to risk adjust anything because it's
a fixed fee.
The same group of patients, essentially.
Yeah, but it's a fixed fee kind of.
Well, yes, based on history for a patient group that had low risk, high risk people in it already.
The assumption is that your patient group is quite similar over the years.
The assumption would be that, yes. And I don't know, have you encountered something like that with any of your insurers?
No, not yet. I think most of the time that's what's happening right now for volume based, right? Most of the time the negotiations are starting with last year, right? Especially now it's interesting with 2020 COVID, so they start with 2020 levels, so that's I think really interesting. But no, I see that part, but not on value-based healthcare contracts. What we did in the breast cancer contract was also per hospital say, okay, did you make an improvement looking for yourself back last year? So that's the delta.
On outcomes and costs. And,
So
the scorecard.
Yeah, so on the scorecard, what were your delta for last year's score for your hospital? You can also do it, of course, compared to the whole group, but it's, then it will say, okay, for your own hospital, did you make an improvement compared to last year? But then, of course, the one of the difficulty is that if you score for the whole group, if you look at it, if you score the best in class right now, then it's really difficult to improve. So that you get, in a way, punished for being the best in class starting. You can best start very low.
Are you talking cost or quality or both?
Both. And that's interesting. So how do you correct if you're best in class and you can't improve really? If you are best in class, do you want to share your results and how you improved with the others? Because then they will also gain a lot of money. And you get, if you compared with the whole group, then you are best in class, you will be punished also. So that's, I think, a really difficult one.
In your case, they're not competitors though, in the market.
No, for us it worked. But also the best in class still had the problem. They were really difficult to improve because they were already doing it very well.
Yeah. We had this problem in the US with the early ACO models because it was all based on improvement and shared savings. And if you ran an efficient operation, it was hard to wring any more savings out of the machine, let alone to share it. And so there's a lot of discussion about, well, what about improvement goals versus absolute goals, absolute targets versus relative targets. And are you having that conversation about absolute versus relative with your hospitals and or your payers?
Yeah, but that's the interesting. Then you get absolute results. If you're not making that goal and there's a patient in your hospital, what are you going to do? That's really, I think, ethical question in a way, that setting the absolute stage. Because it is for, if you have like a lowest absolute level for safe healthcare, that's, I think you don't want to go below that level. But now we're looking at, is it a 8 or a 9 or a 10? And yeah, that's really difficult discussion also with specialists to say, okay, but then I have to do patient selection or different treatment options, or so that's one of the difficulty, I think, for the model.
Some of the discussion is, and I talk about the absolute versus improvement. I'll use as a professor, I'll use the student example. We want them all to be at A students. Some are already A students, so if we pay them for improvement, it's hard to improve beyond an A. But if you're struggling, then improvement is the right answer. More so than absolute, like you said, because we don't want to penalize if for whatever reasons, their fault or not their fault, that they're below. But at the same time, not penalize the high achievers. And so how can you use absolute and relative goals and still be scalable? Because if we say, oh, it depends on the hospital, that's hard to be scalable.
And especially it depends on which stage of cancer you have, for example. So it's more complicated even than one hospital, let alone if you want to do it across the whole continuum of healthcare, for example, for stroke patients. So that's one, I think, the challenge of making a scalable value-based model is about this part. How does that work? And it's also what we see quite often is, for example, with stroke care, 6 patients, they are the length of stay for 16 normal stroke care patients. So that's chance. I mean, that's the difficult part, of course, but you can capitate, you can make maximum for that part, but still, sometimes it's really influence your outcomes. That's also what we see in the data. So that's, I think, one of the problems on making such a model. But it's really interesting if you aim for the improvement, we have also the example, should you benchmark with international or national? Or what we also ask ourselves, should you put money on that absolute level? Or should you incentivize your students for making the effort in learning, improving, and that you see the A+ student, you can see how does he help others, and you can incentivize a student also for other stuff. Then he should stay the A level, of course, there's no debate, but also you can incentivize perhaps the learning and the learning from others. So that's a bit of our going on debate. How can you stimulate not only the A, B, etc., but also if you look a bit wider, what's the purpose of the contract? The purpose is not incentivizes, but the purpose is that everybody gets better students or better results for the patient in this case.
Which should be intuitive for clinicians, because part of their learning model is to see one and then do one and then teach one. So maybe it's like that.
Yeah,
They're in the doing and they're mastering that, so now they move to teaching.
Nobody wants their patient unnecessarily in hospital. But then you get punished for being an A+ student. That's what we're doing right now, right? That's really difficult. There's a difference between punishing and not incentivized. There's a different way in it. So that's, I think, what we said. If you reduce the punishment part, it doesn't necessarily mean that you incentivize the A+. And so that's one of our ideas if you can incentivize the learning and the improvement and setting the stage higher. Yeah, you can debate a lot about what's an A+ student, right? But of course, that's individual work. So, and then again, scalability is the issue, right? Because if you have like the whole university, it's more complicated. And of course, I understand also the healthcare insurance. We want to be able to do some measurements. I understand that part also.